kid on the table is 19 years old and has 3 gunshot wounds, one in the liver, one in the left lung, and one that nicked the femoral artery. You have 11 minutes before he bleeds out. Your hands are steady. Your breathing is controlled. You have done this 400 times. But this story starts 15 years before this moment, sitting in a plastic chair in a fluorescent-lit hallway at a state university, staring at a letter that says you have been accepted to medical school. You are 22 years old. You owe $47,000 in undergraduate loans. Medical school will add another $320,000. You have not made a dollar as a doctor, and you already owe more money than your parents' house is worth. Orientation day, 200 students in an auditorium. The dean stands at the podium and says, "Look at the person to your left. Look at the person to your right." In 4 years, one of you will have seriously considered dropping out, and the other will have had at least one mental health crisis requiring professional intervention. Nobody laughs because nobody thinks he is joking. Your first anatomy lab. You unzip the body bag and the smell of formaldehyde hits you so hard your eyes water for 20 minutes. The cadaver is a 73-year-old man. His chart says he donated his body to science. You cut into human tissue for the first time. Your scalpel shakes, the layers of skin, fat, fascia, and muscle peel apart under your blade. You find the brachial plexus, a tangle of nerves that controls the entire arm, and you trace each branch with a probe until you can name them all from memory. You will spend 6 hours in this lab today. You will dream about nerve pathways tonight. By the end of first year, 14 students have dropped out. The content is not the problem, the volume is. You are expected to memorize 10,000 new medical terms, the biochemistry of every metabolic pathway in the human body, and the anatomical position of every organ, vessel, and nerve in 10 months. You study 14 hours a day. You eat standing up. You forget what your friends' voices sound like. Third year. You step onto the hospital floor for the first time with a white coat that is 2 inches too long and a stethoscope you barely know how to use. You are a medical student on clinical rotations. You know nothing useful. Everyone knows it. The residents tolerate you. The nurses ignore you. The attending surgeon looks through you like you are made of glass. Your surgery rotation begins at 4:30 in the morning. You round on patients, check labs, write notes, and scrub into the operating room by 7. You stand in the corner holding a retractor for 6 hours while the attending performs a Whipple procedure, removing the head of the pancreas, part of the small intestine, the gallbladder, and the bile duct. Your arm goes numb at the 2-hour mark. You do not move it. You do not shift your weight. You stare at the surgical field and try to learn something. On your emergency medicine rotation, you see your first death, a 41-year-old woman, motorcycle accident. She arrives with her left leg nearly severed below the knee and a blood pressure of 60/0. The trauma team works for 47 minutes. CPR, blood transfusions, a thoracotomy. They crack open her chest and manually squeeze her heart. You stand against the wall, watching. Her heart does not restart. The attending calls time of death. Everyone walks away to the next patient. You stand there staring at her open chest for a full minute before someone tells you to move. That night you sit in the hospital parking garage in your car and cry. You call your mother. She asks if you want to come home. For a moment, one long, terrifying moment, you almost say yes. You have graduated medical school. You are a doctor, and you know absolutely nothing about being a doctor. Intern year, PGY1, emergency medicine residency. You are assigned to a Level I trauma center in a city with one of the highest violent crime rates in the country. Gunshot wounds, stabbings, car wrecks, overdoses, heart attacks, strokes, and the kind of human suffering that doesn't make the news because it happens every single night. Your first shift is a 12-hour overnight. By hour 2, you have a waiting room with 37 patients. A man with chest pain, a teenager with a broken arm, a homeless woman with a wound on her leg that has been infected for 3 weeks and smells so bad the nurses have Vicks Vapor Rub under their noses. A 4-year-old with a fever of 104.2 who is screaming so loudly you cannot hear the mother's answers to your questions. You order the wrong lab on a chest pain patient. The senior resident catches it. He does not yell. He says very quietly, "If I hadn't caught that and we missed the troponin and he had a STEMI in the waiting room, he would be dead. Do you understand? You understand. You will never make that mistake again." You will make 1,000 other mistakes this year, each one a lesson paid for in terror and shame. By month 6, you have intubated 19 patients, performed 4 chest tubes, reduced dozens of dislocated joints, and stitched more lacerations than you can count. Your hands are steady now. Your voice does not shake when you talk to patients, but you still hear the monitor alarms in your sleep. Year 2, you are no longer the newest person in the room. A new class of interns has arrived, and they look at you the way you looked at the senior residents a year ago, like you know what you are doing. You do not. You are just better at hiding it. You are running your own resuscitations now. A 67-year-old man comes in full cardiac arrest, pulseless electrical activity. His heart is producing rhythm on the monitor, but it is not actually pumping blood. You run the code. Epinephrine 1 mg IV push. CPR. Reassess. Epinephrine again. CPR. You cycle through the ACLS algorithm from memory while simultaneously trying to figure out why he arrested. Pulmonary embolism. Massive, you call for TPA, a clot-busting drug that is your last option. You push it. 60 seconds, 90 seconds, the monitor shows a rhythm. You check for a pulse, it's there. Weak, thready, but there. He is alive because you made the right call in under 4 minutes. You ride the high for about an hour. Then a 19-year-old comes in with 2 gunshot wounds to the abdomen. His blood pressure is dropping. You call a trauma alert. The trauma surgeon arrives in 6 minutes. In those 6 minutes, you place 2 large-bore IVs, hang a unit of O-negative blood, perform a fast ultrasound that shows free fluid in the abdomen, and keep talking to the kid. He asks if he is going to die. You say no, you don't know. He goes to the operating room. He survives. You find out 3 days later from the surgery team. Nobody tells you about the outcomes. You stabilize, you treat, you transfer, and you never find out what happened. The ER is an assembly line of human misery, and you are the first set of hands. You are the senior resident on shift. The attending is in the department, but they defer to you on most cases. You are managing the entire emergency department, 23 beds, 6 residents, 4 nurses, 2 techs, and a waiting room that never empties. Mass casualty incident. A bus carrying 42 passengers rolls over on the highway. 23 patients arrive in 17 minutes. You triage. Red tag, immediate life threat. Yellow tag, serious but can wait. Green tag, walking wounded. Black tag, dead or unsavable. You make these decisions in under 30 seconds per patient, based on respirations, pulse, and mental status. A woman with a flail chest, multiple broken ribs creating a free-floating segment, gets red. A man with a broken wrist gets green. A child who is not breathing and has no pulse gets black. You tag the child and move on. The child's mother sees the black tag. She screams. She grabs your arm. You look her in the eyes and say, "I am so sorry, but I have to help the people I can save." You walk away. You will think about that sentence every day for the next year. You manage 17 critical patients simultaneously. You intubate 3. You place 2 chest tubes. You activate the massive transfusion protocol twice. Every bed is full. Every monitor is alarming. Every nurse is asking you a question. You operate on pure protocol and instinct, your brain processing inputs faster than your conscious mind can follow. When the last patient is stabilized, you walk to the ambulance bay, sit on the bumper of a parked ambulance, and stare at the concrete for 15 minutes. A paramedic brings you a cup of coffee. You don't drink it, you just hold it. You are a board-certified emergency medicine physician. You completed 4 years of medical school and 4 years of residency. You have $270,000 in student loans. You are 30 years old. Your first shift as an attending is terrifying in a new way. There is no one above you, no senior resident to check your work, no attending to overrule your decisions. Every order you write, every medication you prescribe, every patient you discharge, it is all on you. If you miss something, there is no safety net. You develop your rhythm. You see 28 to 32 patients per shift. Each one gets an average of 12 minutes of your direct attention. In those 12 minutes, you take a history, perform an exam, order tests, interpret results, make a diagnosis, initiate treatment, and either admit or discharge. Meanwhile, 3 other patients need you simultaneously. The lab is calling with a critical result, and a nurse is telling you that the patient in bed 7 just pulled out his IV and is trying to leave against medical advice. A 44-year-old woman comes in with a headache. She rates it a 6 out of 10. She's had headaches before. Everything in her presentation screams benign tension, headache, migraine, stress. Something in her gaze makes you pause. Her left pupil is 2 millimeters larger than her right. You order a CT angiogram. Berry aneurysm, 6 millimeters. It hasn't ruptured yet. If you had sent her home with ibuprofen, she would have died in her sleep within a week. You saved her life because of 2 millimeters. This is the job. Everything matters. Nothing is routine. 5 years as an attending. You are now the trauma team leader at a Level I trauma center. When the worst of the worst comes through those doors, the penetrating chest wounds, the degloving injuries, the burns covering 60% of body surface area, you are the person standing at the head of the bed calling the shots. A 28-year-old construction worker arrives after a 4-story fall. GCS of 3, the lowest possible score. Unresponsive, both pupils fixed and dilated, bilateral femur fractures. Open book pelvic fracture, blood pressure undetectable. The paramedics have been doing CPR in the ambulance. The flight nurse looks at you and shakes her head slightly. You run the trauma protocol. Airway intubated in the field, confirmed placement. Breathing, bilateral breath sounds absent on the left, chest tube placed. 600 milliliters of blood returns. Circulation, massive transfusion initiated, pelvic binder applied. You call neurosurgery, orthopedics, and interventional radiology simultaneously. The resuscitation takes 41 minutes. His blood pressure stabilizes at 88/52. He goes to the operating room. He will survive. He will never walk again. You present the case at Morbidity and Mortality Conference the following week. 30 physicians in a room, dissecting every decision you made. asking whether earlier intervention could have preserved neurological function. You defend your decisions calmly. You know you made the right calls, but right in trauma medicine doesn't always mean good outcome. Sometimes right just means alive. Your residents watch you during these cases. They see someone who is calm, decisive, in control. They do not see the person who sits alone in the physician lounge afterward, staring at their hands, wondering if those hands moved fast enough. 15 years in emergency medicine. You are the medical director of a major emergency department. 112,000 patient visits per year, 87 physicians, 300 nurses, and a budget of $44 million, all under your authority. The job is no longer about saving individual lives. It is about building a system that saves lives consistently when you are not in the room. You write protocols. You review adverse events. You sit in meetings with hospital administrators who want to reduce door-to-doctor times and increase patient satisfaction scores while cutting nursing staff. You fight for resources. You lose more often than you win. A patient dies from a missed sepsis diagnosis. The attending on shift was a physician you trained. You review the chart. The vital signs were there: heart rate of 112, blood pressure of 90/60, temperature of 100 and 1.8. The lactate was 4.2. The antibiotics were ordered 47 minutes after arrival. The standard is 17 minutes. That is the gap between life and death, and it exists because the department was at 130% capacity. 3 nurses called in sick, and your attending was simultaneously managing a cardiac arrest in the next room. You sit across from the physician in your office. He knows what happened. His eyes are red. You do not blame him. You blame the system. You redesign the sepsis screening protocol that week. You add an automated alert to the electronic health record. You petition administration for 2 additional nurses per shift. You get 1. You attend the patient's family meeting. The wife, the 2 adult children, they want to know what happened. You tell them. You say you are sorry. You mean it. The daughter asks, will this happen to someone else? You say, I am doing everything I can to make sure it doesn't. You go home that night and sit in the dark kitchen until 3 in the morning. A mass shooting, 16 victims, multiple dead on scene. The survivors are coming to your department, all of them, because you are the closest level trauma center. You activate the hospital's mass casualty plan for the first time in your career. You call in every off-duty surgeon, every available OR team, every unit of blood in the hospital, and from the regional blood bank. You convert the waiting room into a secondary treatment area. You station a physician at the ambulance bay doors for immediate triage. They arrive in waves. The first ambulance carries a 14-year-old girl with a gunshot wound to the chest. Her eyes are open. She is breathing barely. Her blood pressure is 70 over palp. Your hands are inside her chest within 4 minutes, an emergency thoracotomy, cracking the sternum, reaching in to clamp the bleeding pulmonary vessel. Her heart is beating. You hold it in your hand and feel it quiver. You clamp the vessel. The bleeding slows. You call for cardiothoracic surgery. She goes to the OR. She will live. Over the next 3 hours, you manage the care of 11 critically injured patients simultaneously. You make allocation decisions that will haunt you. Which patient gets the last available OR? Which patient gets the last 4 units of O-negative blood? Which patient gets the on-call neurosurgeon while the other waits? These are not medical decisions. They are moral ones. You make them in seconds because you do not have the luxury of deliberation. When it is over, you walk to the chapel on the 2nd floor. You are not religious. You sit in the empty room and stare at the stained glass. Your scrubs are soaked with the blood of people you have never met. Your hands are trembling for the first time in 15 years. A nurse finds you there an hour later. She sits next to you. She doesn't say anything. Neither do you. You are 57 years old, 30 years in emergency medicine. You have treated over 200,000 patients. You have held the hands of the dying and delivered the worst news imaginable to thousands of families. You have lost count of the lives you have saved because you stopped counting 15 years ago. Your body has been shaped by decades of 12-hour shifts on your feet. Both knees have been replaced. Your lower back aches constantly. You carry reading glasses in 4 different pockets because your near vision started failing at 48 and you refuse to slow down. Your blood pressure runs high. Your cardiologist, a former student of yours, tells you to reduce stress. You both know that is not going to happen. You are training the next generation now. You teach at the medical school. You run the simulation lab. You stand behind residents during their first codes and their first deaths, and you say the things that someone said to you decades ago. You did everything right. The disease killed the patient, not you. You don't know if they believe you. You didn't believe it when you heard it either. A resident comes to your office on a Thursday afternoon. She closes the door. She is crying. She lost a patient, a 6-year-old with meningococcemia who deteriorated faster than anyone could have intervened. She asks you, does it ever stop hurting? You are quiet for a long time. Then you say, no, and if it does, you should quit. Because the day it stops hurting is the day you stop being a good doctor. You drive home that evening. The highway is quiet. Your phone is on the passenger seat, the same phone that has interrupted every dinner, every birthday, every quiet moment for 3 decades. You think about the cases you carry, the ones you got right, the ones you got wrong. The infant who coded in your arms at 3 in the morning in your second year, whose face you still see when you close your eyes. The woman with the aneurysm and the 2 mm pupil. The 14-year-old girl from the shooting. She graduated from high school last spring and sent you a letter. You keep it in your desk drawer. You pull into the driveway. The house is dark. You sit in the car for a moment, hands on the wheel, engine running. The porch light turns on. Your wife is standing at the door, the one who stayed, who understood, who slept alone on 1,000 nights while you stood under fluorescent lights trying to hold back death with your bare hands. You turn off the engine. You walk inside. The phone buzzes in your pocket. You check it. You always check it.